My name is Julienne Anoko. I am social anthropologist from the Sorbonne University. I'm also trained in epidemiology and public health and gender and health. I'm currently a regional advisor for risk communication and community engagement, social anthropology at the WHO Regional Office for Africa. I'm based in Dakar, Senegal, and I'm working for the Emergency Preparedness and Response Program, mainly the preparation. Well, I wanted to share with you two experiences of community engagement among all the many others that I've implemented during most of the emergency response that I participated in. One of the experience is this example happened in the village of Parcoloma, district of Azuay, in the southern part of Ecuador Republic in South America. The community who implemented the project is the Indian Achuar of the Andes region. I would like to explain to you first the emergency situation. What was the emergency situation? The situation was the H1N1 pandemic influenza response. Many people were infected in that region, and unfortunately, a political authority died from the disease. In terms of social issue, there was a serious concern regarding Achuar ethnic group people. Many among them was also infected, but they didn't take the risk seriously. They just think that it was just a flu, a normal flu, and they didn't take it seriously. They were dying. This is why it was urgent to work with them, to involve them, to understand their way of doing things, of also their health-seeking behaviors, in order to engage them to fight the disease. The main intervention we carried was that we developed and implement a community engagement project to fight the H1N1 in the respect of those people's cultural specificity. The aim of our intervention was to bring the community to take ownership of the project from the design to the implementation.
Thank you.
So partners who were involved in this project was mainly from WHO headquarters, the PAHO, the WHO Pan American Regional Office, the WHO country office in Ecuador Republic, mainly the health promotion units, the Ministry of Health and their health promotion department, social anthropologists, the district administrative authorities, the district chief physician, health information facilitators, primary healthcare facilitators, community health workers, community leaders, shamans, teachers, student, parents association, household representatives, rural medias, community social mobilizers, and a private communication agency. The particular consideration regarding the traditions of Achuar people was that they didn't use to ventilate their home, because if they ventilate their home, the risk is that bad spirit can come into the home and attack them. So their home is a sort of big tent with only one door. There are no windows. Regarding this, the main message, one of the main message was that if you want to push the virus away, of the virus of the respiratory disease away, you have to ventilate the house. And they didn't accept this message because they were not able to put it in practice. So we avoid using the messages. Instead, we reinforce the message of staying outside the house, the home, as much as possible during the day, as they used to do, and close the door to avoid mosquitoes to go into the home. This was what the message that we use while abandoning the message of opening the home and ventilating. We developed some strategy, but I will just explain to you the main strategy that and approach that we implement to engage the community. First of all, the team of anthropologists and local health authority met the community to present the project and collect their feedback and agreement to take ownership of the project. Community leaders held internal meeting and settled a team for the implementation of the project. After that, the team of anthropologists conducted a social anthropological research to understand the local context, the perception and diseases, the perception of the disease and of respiratory disease, the perception of illness and sickness, health-seeking behaviors, social organizations, funeral rites, factors that may affect people's health care practices, etc., etc. Local people was involved as investigators, and they were trained by a team of anthropologists. After that, there was a discussion of the result of the research with the community during community dialogues, which make that they agree, the community and the responders agreed and validated the main recommendation and insights. Based on the results of the research, they designed the social mobilization action plan and activities together with community project team that was put in place by the community. The community agreed on 7 H1N1 messages. There were 9 messages, but they analyzed the 9 messages, and they decided that they can only implement 7 because the 2 other messages was not fitting with their cultural way of life. And they were not able to implement those messages. This is why they just chose the 7 messages that they would be able to implement. Based on the result of the research again, they designed this social mobilization plan, the activities together with the community team. The community targeted children as a specific group of social mobilization activities. Under the supervision of their teachers, community designed the communication strategies. This consisted on the following activities, and not only. First of all, they trained teachers, puppeteers, and selected leaders to sensitize their community. This training was done by the response team, by myself and the rest of the team. Capacity building of the community project team on how to monitor the effectiveness of the activities. This was also done by us, by the responders of the outbreak. The production of IEC materials and of cartoons, health forums with Q&A, children drawing competition on the topic of prevention of the disease in my community, a song using preventive messages, fun workshops were the main activities that the community selected according to their own reality. And they were also worried to implement effectively the activities that they will choose. The dissemination of the selected messages in a daily basis in the rural radio called Radio Novela and by town criers and teachers. A private communication agency designed the drawings save song to a CD disc, developed puppets. One of the tips for community engagement in this case was maintain iterative feedbacks to the community, to progressively review the social mobilization action plan and provide them with an on-job capacity building. We had some challenges. The main challenge was regarding the availability of response teams to take time to work hand in hand with community and adapt their agenda to the community one. With community, we never had any challenge because by the moment the project involved them since the beginning into the design, the implementation, and up to the monitoring and evaluation, there were no challenge with community. Key result that we collected from this experience: teachers, puppeteers, and selected leaders sensitize continuously their community. The proper community produced a song that was broadcasted in between popular soap operas. IEC material produced were identified and designed by community, like cartoons that were designed by children following a competition, puppets, leaflets, posters, etc. And all these was posted in private and public places. There were many living rooms with the poster that the community designed by themselves, and that was produced by the communication private agency that we recruited. A community project team monitored the effective implementation of all the action plan and reported to the primary healthcare physicians. Key messages were designed on the model of the popular game known as Faces and Gesture game. The key insight and lesson learned, some of them are the following. Community engagement need a multi-sectorial teams composed by social and medical experts, community leaders, administrative authorities, etc., etc. The approach of full involvement of the community into the program and giving ownership to the community was key for their engagement. Starting by a social anthropological research that involves community teams was key for community ownership of the overall project. When response teams assume the role of facilitators, such as training, supporting, providing resources, they can empower the community. Community leaders much appreciated and expressed their thanks to that their traditions and way of life were taken into consideration. And they were given the opportunity to be understood. These are the main results on how we carried and we implemented this project in Ecuador during the H1N1 pandemic influenza. This was in 2009 and 2010. But I think the lesson learned from this experience we are still using this lesson learned up to today, as we did lately on the Côte d'Ivoire during the last Ebola outbreak or in Guinea.